So let's start. Submental. We'll put lymph nodes aside because that is a completely different lecture. So non-nodal masses. So if you put lymph nodes aside, these are the only things that will happen midline. So you know it's either going to be a dermoid, epidermoid, midline, it's going to be a ranula, and if it crosses into the submandibular space, it will become a plunging or a diving ranula, a thyroglossal duct cyst, or an ectopic thyroid. So even before you start scanning, your mind already tells you, there's a lump in the midline. These are the only 3 or 4 things it can be. So your differential diagnosis is narrowed even before you start the search. We know everything about dermoid, epidermoid, teratomas. I'm not going to take you through all this because all this is known. I'm just going to show you the mass, its location, and how some features will help you make the diagnosis. So let's look at some dermoids, epidermoids. Remember, epidermoids have more fluid. Dermoids usually don't have that much fluid. So to distinguish an epidermoid from a dermoid is usually the amount of fluid that is there within that lump. Sometimes in an epidermoid you will see squamous pearls inside. Those are, squamous cell nests that have coalesced together. So if you see squamous pearls, this is more likely going to be an epidermoid, or rather not a dermoid. So these are a few clues that will separate an epidermoid from a dermoid, but its location is the same, midline. So let's have a look. Now when we did the anatomy, remember this is transverse, this is transverse submental. So that's the anterior belly of the digastric, that's the anterior belly of the digastric. This anterior belly on the right, this is anterior belly on the left, that's the mylohyoid, that's the mylohyoid. I should have seen the geniohyoid over here, I should have seen the genioglossus over there. Normal anatomy should have been anterior belly of digastric, mylohyoid muscle, the geniohyoid, and the 2 trouser legs of the genioglossus. I am not seeing the geniohyoid, I am not seeing the genioglossus. Again, this is your first clue. Distortion of anatomy or loss of normal anatomy is your first clue that there is something happening there, there is something over here that should not be there, and you see this large mass which contains fat inside it. This is bright, it's echogenic, it's got small so-called nodules inside that, and at that location this is most likely going to be dermoid, and when you do an MRI you see that sac of marble appearance that is classically described for a dermoid. So here your clue was lack of normal anatomy. I do not see the geniohyoid, I do not see the genioglossus, so that tells me that there is something wrong over here. I see a fat containing structure, so that tells me it's likely going to be a dermoid or an epidermoid, but an epidermoid over here has more fluid. An epidermoid over here has more fluid. So this one is an epidermoid, that's a dermoid, and you can see these small bright echogenic foci inside, that's the squamous pearls we were talking about. Now, another thing you should remember, when we say congenital cyst, like an epidermoid or a thyroglossal duct cyst or a branchial cleft cyst or a thymic cyst, when we use the term congenital neck cyst, when you hear the term cyst, what it tells you, thin-walled anechoic posterior enhancement, it has been ingrained into us that all cysts are thin-walled anechoic and posterior enhancement. In the head and neck, that does not work. In the head and neck, most cysts are going to be like this, the pseudo-solid appearance of a cyst, because they contain a lot of debris. This is desquamated epithelium inside the cyst. So most cysts, thyroglossal duct cysts, branchial cleft cysts, epidermoid cysts will have this pseudo-solid echo pattern. They are not going to be anechoic. Of course, there will be some, there will be anechoic, but the classical description of a cyst that everything must be anechoic, that does not hold true in the head and neck. How do you know this is a cyst? You can either push on that nodule there, you will see motion of fluid or motion of debris within that cyst, or you can simply push Doppler through it. You're not using Doppler for vascularity, you're using Doppler for its power. The moment you were putting Doppler through it, this debris starts to move underneath that Doppler energy. So you can just turn on the Doppler and you will see this debris moving. So please remember, cysts in the head and neck are not necessarily anechoic, thin wall with posterior enhancement. Midline. Midline masses, like we said, dermoid, epidermoid, ranula. In young patients, usually low down in the neck, just towards the hyoid bone, where you would normally see a thyroglossal duct cyst. The location of a thyroglossal duct cyst is also the location of a dermoid. So how do you separate a thyroglossal duct cyst from a dermoid? Is this a thyroglossal duct cyst? Is this a thyroglossal duct cyst? We don't know. The location of both is the same. What does anatomy tell me? That infrahyoid thyroglossal duct cysts are embedded within the strap muscle, so they must be within the strap muscles. Whereas dermoids are superficial to strap muscles. They displace the strap muscles and they are not embedded. So I know the differential diagnosis of this is either a thyroglossal duct cyst or a dermoid. I'm not looking at the appearance, I'm simply looking at this. That is the strap muscle over there. This nodule is not embedded in the strap muscle, it is anterior to it, it is displacing the strap muscle. Same over here, the nodule is anterior to the strap muscle and displacing it. So this cannot be an infrahyoid thyroglossal duct cyst, this must be a dermoid. So once again, simple anatomy, what it does to the muscle is what is guiding you towards your diagnosis. The appearance is separate, that's not a problem. But if you go simply based on anatomy, this displacement of the strap muscle does not happen with thyroglossal duct cyst. This cyst will be within the strap muscles, it's embedded inside it, and that is embryologically because the track runs through the middle third of the hyoid bone, runs through that strap muscle, so you know that is where a thyroglossal duct cyst is going to be. So simply based on location, all that we're talking today is location, location, location. Now ranula versus diving ranula. A ranula is a retention cyst of the sublingual gland. Once that cyst crosses the mylohyoid muscle and enters the submandibular space, it becomes a diving ranula or a plunging ranula. So I am not interested in how it looks. I am simply looking at where it is and what does it do to the mylohyoid. So here we are. There is a cystic structure over here. There is the mylohyoid muscle there, sublingual gland. And there is a cyst over there. It is located a little far away, so I can't see it very well. But it does not cross the mylohyoid. It stays inside the mylohyoid. So I know that this is going to be a simple ranula, simply because it is restricted in the sublingual space. Now have a look at this one. This is again a cystic structure with debris inside it. Now I'm just going to run the clip for you. So this will be the sublingual space here. This will be the submandibular space here. I'm going to run this clip for you. See what this cyst does. And have a look. That is the mylohyoid muscle there. From the back of the mylohyoid, so from the sublingual space, mylohyoid, from the back of the mylohyoid, it enters the submandibular space. So like we said, the back of the mylohyoid is the free space that allows diseases to go from sublingual to submandibular and even medially into the parapharyngeal space. So just because it is crossing the mylohyoid, it starts in the sublingual, crosses the mylohyoid, enters the submandibular space, by its anatomical definition, I know that this is going to be a diving ranula or a plunging ranula, and an MR confirms both, the ranula on top and the diving ranula below. So again, simply based on anatomy, what it does, not what it looks. So what it looks is part 2. Very often you do not even require what it looks because the part 1 will tell you the diagnosis. Now let's have a look at thyroglossal duct cysts, because these are very common. Most of them are infrahyoid. More than 60%, 70% are infrahyoid. Then is at the hyoid bone and few suprahyoid. So Remember, it is embedded in the strap muscle if it is infrahyoid. So most thyroglossal duct cysts will be embedded within the strap muscle, and that is your simple clue. I'm going to run this movie clip. This is transverse, this is longitudinal, that will be the hyoid bone over there. That is the hyoid bone over there, and this is transverse. Have a look. A suprahyoid thyroglossal duct cyst at the floor of the mouth. At its location in the midline, at the floor of the mouth, a pseudo-solid cystic appearance. The differential diagnosis will be an epidermoid or a thyroglossal duct cyst, but at that location at the floor of the mouth, a thyroglossal, a suprahyoid thyroglossal duct cyst is most common. So simply by its location, I know that this is going to be a suprahyoid thyroglossal duct cyst. Again, look at the appearance now. It is not anechoic, it is not thin-walled, it doesn't have that classic posterior enhancement that we talk about cysts elsewhere in the head and neck. No, elsewhere in the body. Now have a look at these thyroglossal duct cysts. So that will be the hyoid bone, that is the hyoid bone, and that is the hyoid bone. So this is at the level of the hyoid bone, this is suprahyoid above the hyoid bone, and this is infrahyoid below the hyoid bone. So that's the top, that's the bottom for all three. In this, you will see a variety of appearance. This one is almost anechoic. This one has a large anechoic component with debris inside, and this is almost pseudo-solid over here. So the different appearances of a thyroglossal duct cyst and their location, they are located in the vicinity of the hyoid bone. And that is important for a surgeon when he is operating. When you're making a diagnosis of a thyroglossal duct cyst, there are a few things he wants to know. One is its relationship to the hyoid bone. Number two, is there normal thyroid present in the thyroid bed? And number three, does this thyroglossal duct cyst have a solid component that might be a papillary carcinoma within a thyroglossal duct cyst? These are the only three things a surgeon wants to know. Very often these are young children or even babies, and they are very restless. We do not sedate, the mother just holds the baby, and we just do two simple scans. One transverse scan to show its relationship to the hyoid bone, and then look at the thyroid, whether there is a normal thyroid in the thyroid bed, and then one longitudinal again to show the relationship to the hyoid bone and the presence or absence of any solid component. It does not take more than a few minutes, and you are able to give the surgeon all the answers. For him, it is important to know the relationship, particularly infrahyoid thyroglossal duct cysts, because when he operates on them, he takes out the middle third of the hyoid bone along with the cyst. It's called the cyst trunk procedure. So he takes out the cyst and the middle third of the hyoid bone because the track runs through it. If he takes out only the cyst and leaves the hyoid bone, you will have multiple recurrences. And that's why the surgeon is extremely keen to know, tell me its location and relationship to the hyoid bone. This one is a thyroglossal duct cyst with a large solid component inside. This one on biopsy turned out to be a differentiated thyroid cancer, a papillary cancer within the thyroglossal duct cyst. So when you're making the diagnosis or suggesting the diagnosis of thyroglossal duct cyst, these three things must go through your mind. Its location, relationship to the hyoid bone, presence or absence of normal thyroid tissue, and the presence or absence of a solid tumor within that thyroglossal duct cyst, because these do occur. Some people say up to 5%, some people say less, others say even more. So the other thing in the midline is ectopic thyroid. We've seen ectopic thyroids. Now in most places in the world, if you think of ectopic thyroid as a differential diagnosis, you're going to do a isotope scan, because it will pick up thyroid uptake anywhere in the head and neck. And often this ectopic thyroid has multiple foci. It's not only one foci like you see over here, One foci at foramen and cecum floor of the mouth, the other one midline anterior. There are two foci of ectopic thyroid tissue. Ultrasound will be able to pick it out. Ultrasound will tell you this is thyroid tissue. In fact, this girl had multinodular thyroid in the ectopic thyroid tissue. Now, the reason I tell you is multiplicity of ectopic thyroid tissue, because 20 years ago there was a common saying. If you have ectopic thyroid tissue, you will not have normal thyroid in the thyroid bed. So you will have ectopic thyroid and no orthotopic thyroid. So one or the other. But nowadays, no. As imaging gets better and better, you're finding ectopic thyroid tissue and normal thyroid tissue in the thyroid bed. So what we learned 20 years ago, that if you have one, you can't have the other, no longer holds good. So ectopic and orthotopic thyroid tissue can be present in the same patient at the same time. So when you have found an ectopic thyroid tissue, don't stop your search. Keep looking whether there is anywhere else there is ectopic tissue and if there is normal thyroid tissue.